Hi, everyone. Welcome to Care Team Talk. We will be discussing colorectal cancer and some pathology indicators. We have two cases to review with you today. I'm Tammy Triglianos. I'm excited to join Dr. Ang in discussing how we work together to take care of our patients.
So I'm Dr. Cathy Ng from Vanderbilt Ingram Cancer Center here in Nashville, and I'm the director of our Young Adult Cancers Clinic, and also the co-director and co-leader of our GA research program and co-chair of the NCI-GA steering committee. Welcome.
So to start off with our first case of an MSI-high metastatic colon cancer, our first gentleman is a sweet 84-year-old male with a past medical history of diabetes, hypertension, and coronary artery disease. He initially presented with a decrease in his appetite, nausea, and had some progressive weight loss. His workup entailed a MRI, which showed about a 7-centimeter hypoenhancing mass, and a colonoscopy confirmed a partially obstructing mass, as well as an additional non-obstructing 4-centimeter mass in the hepatic flexure. Biopsy confirmed adenocarcinoma. Of note, his CEA was normal at presentation, and he had no evidence of metastatic disease. So he proceeded to treatment with a right colectomy, and his final pathology showed 2 synchronous adenocarcinomas. The cecal mass was a stage 3B, and his hepatic flexure mass was a stage 2A. And of note, his molecular profile included an MSI-high tumor that was more consistent with sporadic origin. So we elected to proceed with surveillance.
So this is obviously a gentleman that we sometimes see in our clinic, right? So this is a patient that has hypermethylation, and if they were to be tested for MSI-high, they would have a positive BRAF mutation because of the hypermethylation. Due to his age, it's clearly not Lynch syndrome. And I think some of the things here that you could see is that because these are supposedly very good prognostic patients with early stage disease, we tend to put them on surveillance.
So after about 6 months after his surgery, he came back with a increasing weight loss and anorexia. His scan showed recurrence with a 7-centimeter duodenal mass causing gastric outlet obstruction. He also had 2 additional lesions noted. And biopsy confirmed recurrence of his cecal adenocarcinoma, once again an MSI-high tumor. And therapy was, we proceeded with immunotherapy with Pembrolizumab.
So I do want to just mention very briefly, although we place this patient on surveillance, we always try to encourage clinical trial enrollment whenever possible. And there is a trial for stage 3 patients that are MSI-high that is ongoing. Regarding this setting where he has recurrent disease, obviously this appears to be because of his high-risk features. This can happen with our patient population, even though they appear to have a good prognosis. Pembrolizumab, as many of you know, is currently FDA approved based upon Keynote 177, noting an improvement in basically progression-free survival for our patient population that are treatment-naive MSI-high with metastatic colorectal carcinoma. And so the PFS actually doubled at 16 months versus 8 months roughly for patients that had received Pembrolizumab. And that was a phase 3 clinical trial. So sorry, I did want to mention the recent update did show that the investigators did not meet their primary endpoint of overall survival, but keeping in mind, I apologize, 60% of the patients did cross over because that was allowed as part of the protocol. So once again, though, Pembrolizumab would be considered the standard of care for a treatment-naive MSI-high metastatic colorectal cancer patient.
So before I share what his response to therapy was, I think it's important to mention immune-related toxicities, being aware that essentially any autoimmune side effect in any organ can happen at any time. So there's lots of references, I'm particularly sharing the link for the NCCN practice guidelines, and I think this picture depicts the vast side effects that you need to be aware of.
And I think that's very important to keep in mind. For single agent immunotherapy, it's less likely to have significant toxicities, although it can happen. And as you can see here, every single organ can be involved, although we more commonly see thyroid disorders and there is a risk of colitis. But when you provide combined immune checkpoint inhibition, that's when you have a higher risk of immune-related toxicities. And keeping in mind for treatment-naive patients, there's phase 2 data, not phase 3 data, but phase 2 promising data in a single arm study of nivolumab plus ipilimumab in Checkmate 142, which actually reported a response rate as high as 67% versus 44%. Once again, I don't like to compare trials, but 67% for single arm phase 2 of nivolumab plus ipi versus pembrolizumab in the phase 3 study, which had a response rate of about 44%.
And I'm happy to share that this patient had really great tolerance to his immunotherapy. His side effect was really only some dry skin and rash, managed pretty well with some Kenalog cream and skin moisturizer. So he did well.
Great point. The skin toxicity is a commonly seen toxicity.
So I'm excited to share with you all the great response that this patient had. So as a reminder, the first screenshot is his recurrent disease with that 7-centimeter mass. And this second picture is his first efficacy scan, which you can't really see the mass at all. And of note, the radiology report actually read interval mass removal, which his patient didn't even undergo surgery at this time for this recurrence. So really awesome response. He completed 2 years of immunotherapy. He had no evidence of disease at that 2-year mark on imaging, and now he's on surveillance.
This is a great story. I mean, demonstrating the true benefit of immunotherapy in some select patients that are MSI high. And, you know, in this setting, is this somebody that you would want to get a biopsy on to confirm it? I don't know if it's necessary, especially if the patient's asymptomatic. I've seen and heard cases where obviously a biopsy is completed or surgical resection is completed and they tend to see a lot of fibrosis. So this is just a wonderful story about the benefit of immunotherapy in MSI high patients. Now, keeping in mind, there are about a third of patients that don't necessarily respond to immunotherapy, even though they're MSI high, and we really don't know the reason for that at this time. There's lots of investigative work ongoing regarding that matter, but this is a wonderful story. And I'd love to see, like, how are you following him on surveillance now?
Every 3 months, he's really just had his first surveillance visit. So we're early on in this surveillance and stopping, but he is doing well with no recurrence. And I think the other note about this, with him not being exposed to FOLFOX in the adjuvant setting, elderly man, neuropathy from his diabetes. So he didn't have to undergo that toxicity from chemotherapy. And so just a really great story.
Yeah, I mean, I think this really brings to mind, obviously, in the real world setting, right, we really see patients with other comorbidities and we have to take those things into account. So luckily enough for him, he was MSI high, and then you were able to avoid potential toxicities from systemic chemotherapy because of that.
So now we will switch gears, going to the opposite age spectrum and talking about rectal cancer in a young adult. This very sweet young woman is 30 years old. She has no past medical history, young, healthy, energetic woman. Her presenting symptom was bright red blood per rectum that waxed and waned, but since it was fairly persistent, she did undergo evaluation. So she did have a partially obstructing mass in the rectum on colonoscopy. Biopsy was positive for adenocarcinoma and was microsatellite stable. Her MRI did show a T4B N2 rectal tumor. Her CEA was normal at diagnosis, and she did not have any evidence of metastatic disease. So she proceeded with total neoadjuvant therapy with FOLFOX followed by long course chemoradiation.
So I think this story, unfortunately, is something that we are more commonly seeing in our clinics. As most people are aware, as probably most of the people involved in this conference, there's an expected rise over the next decade for left-sided tumors and rectal cancer. I mean, it's reported to be as high as 124%, despite the fact that, I apologize, my dog just sneezed, so sorry about that. So rectal cancer is expected to rise as high as 124% over the next decade, despite the fact that this is a small portion of our patient population. And I think it's really important when we're seeing, especially female, when we talk about fertility and other aspects of being diagnosed at a young age, these things really need to be discussed. And whether or not they want to consider preservation, fertility preservation, and to make sure that they are referred to the right specialist. I think it's very interesting. Your patient, I think you had mentioned, didn't want to undergo chemoradiation therapy at first, and that's why she opted for chemotherapy first. And because it's a mid-line tumor and it's a T4B N2, I completely agree. I would favor also adding on the aspect of chemoradiation therapy because she's obviously at high risk of recurrence. In high-lying tumors, maybe we can get away with chemotherapy alone, especially since we're waiting for the results of the Prospect phase 3 trial. Hopefully we'll have those results, which is looking at mid to high-lying tumors and omitting radiation therapy if possible. But obviously we understand why she has these concerns. And I think you're going to be talking about the toxicities potentially associated with therapy.
Yeah, and I think that's the important aspect. And when we meet these patients and as the nurse practitioner on the team and working with my physician colleagues, really focusing on the, patient, and she was very upfront and part of her treatment discussion about really wanting to try to avoid radiation, even if at times we don't think that that's possible. I think trying to meet that patient where they are, and whether you do chemoradiation first or chemotherapy first. I don't know if you have some comments on that as well.
Yeah, so one thing I think it's really important to keep in mind, I think we have to, as a physician, I have to thank all of our oncology nurses and oncology advanced practitioners, because often we're running from room to room, and we really support and need the teamwork of our oncology nurses and our APPs to really optimize the care of our patients. So I'm sure there's a lot of additional communication that a lot of the physicians aren't involved in, especially regarding these very personal issues regarding potential toxicities and fertility issues. So I just want to make sure I bring that up and thank all of our APPs and oncology RNs, because it's just an immense part of a critical part of the team. In regards to sequencing, great question. So based upon the data we currently have, we now know that neoadjuvant chemoradiation therapy, based upon the old phase 3 German trial, is a standard of care. The data has shown that if you provide total neoadjuvant, meaning if we provide our chemotherapy and our chemoradiation therapy up front, the patients are more likely to be compliant to completing their course of treatment. And then now there's this interest in non-operative management. So if you give all your treatment up front, is there any potential for, especially for a mid-lying tumor, and it's a higher risk though for a low-lying tumor, is there any potential for sphincter preservation? And I think because we are unfortunately expecting younger patients, and I'm sure this question will come up, we don't know the etiology of why that is happening. That's a lot of ongoing research. But because we're seeing younger patients, this non-operative management is a point of discussion. And I think it's something that has to be discussed, and it's very reasonable with your care team. So in regards to sequencing, The OPRA trial was a phase 2 study looking at sequencing, and in the higher risk patient population, such as this young woman with T4B-N2 disease, they noted if you received chemoradiation therapy first, followed by chemotherapy, then you were had a higher likelihood of having sphincter preservation and non-operative management. But keeping in mind also, there's also the PRODIGE 23 trial, which also did systemic chemotherapy first, and they didn't look at non-operative management, but the outcomes were very good. So it really depends upon what is your primary objective, and really a discussion with the patient. Right now, sequencing is still it's really an area of discussion for any rectal cancer patient. And also there's 5x5 short course radiation therapy based upon the Rapido trial, which was a phase 3 trial, which was also a positive study demonstrating you could also consider 5x5 in patients. So once again, we need more, the sequencing is still a matter of discussion, and really a multidisciplinary approach with your surgical oncologist as well as your radiation oncologist.
Yeah, so we won't spend a lot of time talking about short-term side effects of therapy. I think we're all pretty experienced with FOLFOX, been around for a while, and radiation. But I bring this up because it's important to talk about side effects of therapy upfront, those short-term, but many of those end up being long-term, and how to address those upfront to educate our patients, as well as engage in those resources to help with management, and getting into some long-term side effects, particularly for this young woman who did not have children, but very interested in having children and carrying her own children. So how thinking about ovarian preservation, sperm banking, even sexual function, libido, how this impacts our young population. It's important in our elderly population as well, but they are, in starting out in, marriage and relationships and things like that. I think other aspects, anxiety, fear of recurrence, or if they're metastatic, how the rest of their life will be spent. So engaging with our psychology and psychiatry colleagues, fatigue and energy. Some young people are kind of in that sandwich zone where they're caring for young children and then they're responsible for elderly parents. And how do you have the energy to go through your own treatment with those other personal responsibilities? I think bowel and bladder dysfunction and ostomy and body image, these are really important things to discuss up front. We have an AYA program at our institution, which I'm very lucky to have, and I bring them in early on in a young adult's diagnosis. Career, there's Cancer on Career website, how this impacts, breadwinners of their family. And then, of course, genetic counseling. This young woman, didn't have what, we think is a familiar cancer, but I think our young people should really think about discussion with our genetic counselors.
I fully agree with everything you just mentioned. It's a critical component of optimizing the care of our young adult patient population. Because I was seeing so many of these patients for the past 2 decades that were not supposed to have colorectal cancer, and especially when you're talking about rectal cancer and the potential toxicities associated with radiation therapy and the consideration of a permanent colostomy at times. It's obviously a huge anxiety issue. And so it's wonderful to see UNC has created a program as well. We have our AYA program, but we also created specifically a young adults program for all cancers for individuals between the ages of 20 and 45, just because they didn't really fit the AYA age group, and yet they were too young for the average age patient population. And it's the same thing. It's really to provide as many resources as possible for this patient population. And so I encourage individuals to number one, speak to their physicians. And if their physicians are not providing the resources they need, to definitely be their own advocate and look up multiple resources that are available for the patient population. I'm sure you guys have a website, and we created a website as well, youngadultswithcancer.com, and there's a ton of free resources, and there's national groups that can share counseling, that's free counseling for patients. So it's really just reaching out and really communicating.
Yeah, I mean, 2 points I'd like to point out. This particular woman, you know, lots of creative approaches for her to help support her in, you know, trying to start a family after she gets finished through her therapy. And she had met with our GYN surgeons and had to have her ovaries kind of tacked out of the way of a radiation field. So there's so much to, you know, our young people. So, you know, being aware and connecting with our multidisciplinary, not just surgery, radiation and medical oncology, but even outside of that. And at our institution, we are even working at having a section of our infusion room for our young adult patients. You know, when they're in a large infusion area, and if they're more with the elderly population. So how do we connect our young people to, you know, support each other, because they feel like, you know, kind of different when they see, you know, majority of the people around them if they were elderly. So a great resource for them as well.
Yeah, fully agree with you on all those aspects. And it's really just making sure that they're understood and they don't feel alone.
So I don't think we can talk about colorectal cancer without stressing the importance of screening, especially in our young adult patients. In 2020, about 12% of cases are expected to be under the age of 50. So recently, the US Preventative Service Task Force lowered their recommendation to 45 years of age. Actually, think even lower is reasonable as well. And the most important thing is that even outside of familial cancers, patients with a colorectal cancer, their children should start screening at least 10 years prior to their age of diagnosis. So for this young woman who was diagnosed at the age of 30, if she has children, her children should at least start getting screening at the age of 20.
So it appears we've got a couple questions. I don't know if you want to address them now, Tammy?
Yes.
Says, do you recommend standardized descriptions or AEs as outlined in the CTCAEs? I'm looking for better patient education resources. That's a great question. I would love to, I would have to defer to you on that one.
Do you recommend standardized? Yeah, I'm assuming for immunotherapy.
Yes.
So I think it's hard to have standardized descriptions. I think there's just, you know, a vast range of side effects. ONS actually puts out a great, you know, card. I think having reference cards for patients. So there's so many resources out there. I think, you know, there's lots of friendly ones out there. I don't think I could really target one.
I actually, there's one that I commonly use. So if people want to email me, I can share it. It's my email is cathy.ng@vumc.org. One other question is, what are the factors impacting such a dramatic rise? Thank you. That is expected in colorectal cancer in the young adult. Great question. Unfortunately, I don't have a perfect answer. It's still, we believe it's still multifactorial. Obviously, this is unexpected. Is it due to obesity? Is it due to microbiome? Is it due to other factors? There's been some interesting data to suggest previous antibiotic exposure as a child can impact your risk of colorectal cancer. I would have to say right now, there's a lot of ongoing research. I'm sure at UNC, they're doing a lot of research. We're doing a lot of research as well as other centers. And so we don't have a perfect answer, but that is being investigated. They want to know that 30-year-old did not have any family history of rectal cancer. I believe that's correct. Yes. And the last question is, what is the website? Yes, that's correct. youngadultswithcancer.com. That's our website for our young adults program. So we got some questions, so that was great. But I wish I could remember the website of the one that we use for the AEs, but I'm happy to share it if people want to email me. I just have to double check it. I really enjoyed this discussion, Tammy. I think you brought up, these are very pivotal cases that we commonly see. These are your real life cases, more importantly. So I think it's fantastic. It appears to be that we need to sign off. So what a great time. Thank you it's such a pleasure meeting you, Tammy.
Yes, this was great. Thank you. I've enjoyed chatting with you. And I think we can't stress enough the importance of taking care of our patients and meeting them where they are in their lifespan, and being creative with that for the best interest of the patient. So thank you, Dr. Ang. This was really great collaborating.
Oh, such a pleasure meeting you. Thank you so much.
Bye, everyone. Thank you for joining.
Thank you for our audience.